Hello everyone, I'm Madeline Chamberlain, and with me today I have Catherine Jenkins. She is a APRN MSN FNP-C here at Rocky Mountain Allergy, which is a part of Tanner Clinic, which is like a great big umbrella clinic, lots of different specialty clinics within it here in Layton, Utah. She also contracts with a residential treatment center, and she has been a nurse practitioner for 5 years. So Catherine, if you can think back to when you first started practicing as a nurse practitioner, what was one or two of the biggest struggles you faced as you transitioned from an RN to a nurse practitioner?
I think one of the biggest things is just that as an RN, you always default to a physician, right? Mm-hmm. Whether you have standing orders for something or you're working on the written orders from a physician of some kind, you always kind of default back to them to answer any questions you have or if anything goes wrong. And when you're the provider, you're the one now who is answering all of those questions, and then just kind of figuring out, you do your SOAP notes, right? And have all your assessment piece and coming up with a plan, but you've got to make sure that it's all implemented. And then within that, you suddenly go from working as the RN and having someone over you to being the person that's over the staff underneath you and having to kind of manage all of that in addition to your new role as an NP. It can be kind of an overwhelming process to make that transition. For the most part, like throughout your schooling, you kind of get that under your belt as you've done several hundred or thousands of hours of clinical rotations. But it is kind of taking one hat off and putting another on and having, it's a lot more responsibility. There's a lot more that is as expected of you as it should be, but it can be, for some people, it's a lot of pressure and it's a difficult transition. And then learning curve is huge. It's a big learning curve. I personally think that going from an RN to an FNP or an NP of any kind is nice, because if you've had years of experience as an RN, it does make that transition easier, but the learning curve the first few years can be pretty steep depending on where you work and what you do.
Awesome. So consider your scope of practice and regulatory bodies within your state, and do you agree with the regulations of your licensure designated by the state, or are there any changes to credentialing or clinical privileges you would make?
The only really big thing, and we've kind of worked with legislature to get this changed, and it's still an ongoing process with the Utah Nurse Practitioners, and then as a group, there's a group that's called UNP, and then just as nurse practitioners throughout the state. But even when I was in school, I went up to the day at the legislature, but it's just the physician oversight. We're really trying hard to get rid of that. I do think it has its place in a few types of circumstances, but in general, we're for the most part really well trained, and to have that physician oversight agreement, I think is something that really needs to be gotten rid of, especially because NPs can open their own practices and have autonomy that way, and to have this paper, like a legal document saying that there's someone who would back you up. Most of the time, those people are just getting paid an amount of money to do not a lot, and not always would go and stick their neck out for the NP. Does that make sense? Mm-hmm. Credentialing wise, I just think that for the most part, if we're doing the same job, that we should be getting paid the same as physicians. I think that physicians, NPs, and PAs, if we're all in the same practice and we are all doing the same thing, we should be getting paid the same amount. Now, if there's a physician that's doing surgery and there's, a mid-level, that term, that is, being a first assist or not even in surgery, they're doing follow-ups, then that is understandable. But within a clinic setting, if we're basically doing and seeing and participating in the same thing, we should get paid the same. And I know a lot of times they'll bill incident 2 and have the physician kind of assume the charges for that, and I wish that would be different in some instances. Personally here, there's really not a whole lot that I don't do that the physician that we work with does. Some of that is just by personal preference, but if, for the most part, we do the same things. I have, a lot of autonomy, and I'm able to practice basically, independently and have the privileges that I want here, which is really great.